Hello, and welcome to GAPNA Chat, an official podcast of the Gerontological Advanced Practice Nurses Association. GAPNA Chat provides interviews and discussions with GAPNA leaders and members of the gerontological healthcare community, and will focus on advocacy, policy, education, professional development, research, and clinical care for older adults. Before we get started, a practical guide for the gerontological specialist is now available for purchase in the GAPNA store. This text is a handy resource for anyone caring for older adults and is helpful to those preparing to sit for the Gerontological Specialist Certified exam. Visit www.gapna.org to get your copy. In this episode, Dr. Cassandra Von Ness, a gerontological nurse practitioner and member of the GAPNA communication team, talks with Dr. Rachel Zimmer, an adult gerontological nurse practitioner and assistant professor at Wake Forest University School of Medicine in Winston-Salem, North Carolina. We are pleased to present Dr. Von Ness's interview with Dr. Zimmer.
Hello, this is Dr. Cassandra Von Ness with GAPNA Chats. I'm here to talk with Dr. Rachel Zimmer. Dr. Zimmer is an assistant professor of implementation science at Wake Forest School of Medicine. She's an adult gerontologic nurse practitioner who sees patients in home-based primary care and in marginalized communities. She has founded the Atrium Health Wake Forest Baptist Mobile Health Program that serves the healthcare needs of people who do not have health insurance. Dr. Zimmer has also developed Fresh Food RX, a produce prescription program in partnership with several community-based organizations, providing locally grown produce delivery for people with food insecurities. Dr. Zimmer is active in education and advocacy and serves on several regional and national committees, including the American Academy of Home Care Medicine's Education Committee, the Implementation Science Health Equity Task Force, and the North Carolina Free and Charitable Clinic Health Equity Council. She collaborates closely with various community-based organizations, including Neighbors for Better Neighborhoods and the YMCA. Welcome, Dr. Zimmer, and thank you for joining us today.
Yeah, thank you for having me.
So let's just jump right in. So, Dr. Zimmer, what could you tell an 18-year-old Rachel about her future career path?
So I had to think back to myself at 18 and I don't know. I mean, I think at that time, I remember my only exposure to nursing was a nurse who would come into one of the group homes that I had worked in at the time. And I was actually thinking about going to school for psychology. And I was very intrigued by her. She had come in and she looked like she carried herself well. And I remember her telling me, don't ever go into nursing. I'll never forget her saying that. And what I think is really interesting is that really brought me to a space where I wanted to know more about nursing after that. So that's actually what started my path toward nursing. Somebody telling me not to do it. I guess that's, the 18-year-old in me. And a few things that I've learned along the way is one, nursing is such a flexible discipline. I didn't know where I was going, and I still have been able to sort of be fluid throughout my career. So I think I wouldn't have stressed as much as to figuring out my future at 18. And then secondly, that my perspective is valuable. I think that's something I had to learn over time. Sometimes I would sit in rooms and not believe or think that people could see things the way I saw them. And then I realized, wait, I actually have a very specific and valuable lens that I'm bringing to the conversation. And I don't know that I always appreciated that about myself. So yeah, maybe if I had to go back to myself and say, those would be a couple of things, not to be so stressed about your future.
We all need to give ourselves a little grace, don't we?
Yes.
So you started your nursing career working in bone marrow transplant. What influenced your pivot to gerontological advanced practice?
Yeah, that was a big shift in some ways. In some ways it wasn't. First of all, inpatient nursing, especially in the bone marrow transplant world, I did it for 8 or 9 years, and it can be very stressful. And so you deal with a lot of end of life situations because of the nature of bone marrow transplant and the risk involved. And I had actually started my nurse practitioner program while I was still working there. And I was doing some of my rotations in geriatrics. And I noticed there was a similarity actually in some of the conversations we were having. It was just, I felt that I was already comfortable with the idea of end of life. And not to say that everybody who's an older adult is near that, but just in the old, having those conversations. And then also I started doing house calls, and I've continued to do house calls throughout my career as a nurse practitioner. I love that. I love going into patients' homes and partnering with them to take care of them throughout their lifespan, becoming a part of their family in some ways. So I don't know, that's a very unique part of doing care for older adults, and I've just always appreciated that. So I think just falling in love with older adults, the care of older adults, and then also feeling like I'm a part of their lives in a different way, if that makes sense. Yeah.
So a little further along in your career now, you have really developed a heart for older adults that may be experiencing some food insecurity. What happened that elevated this to the center of your practice? And does this keep you up at night?
That actually, it's interesting. I had to think about that. I started the food prescription program initially in March of 2020. So, that was right at the pandemic. But we were actually doing focus groups before, like in January and February of 2020, because we had already started partnering with community-based organizations around looking at food for older adults. And some of that was because when I do house calls, I would have patients who would be food insecure, right? You would open their refrigerator, as we typically do, and see, oh, my patient has dementia. She's living alone and she has no food in her refrigerator. And some of it is because she can't afford it. Some of it's because she doesn't have people to help her, and so, I would see that time and time again. We would be asking patients to manage chronic health conditions like heart failure, but they wouldn't have the foods that they would need to manage that. And then also our local Meals on Wheels is wonderful, but they also have a waiting list, right? Because they have so much need in the community. And so I wouldn't be able to figure out any other options for people who were having food insecurity and couldn't get access to food. And so I was really having to piecemeal things together, rely on kind of a fragmented system to provide access for our patients. And so when March of 2020 hit, I had already had some foundation funding that I was holding on to start a market with one of our partners. And I went back to the funders and said, I wonder if we could actually start a food delivery program for patients, because when the pandemic hit, patients that we had who were homebound, who weren't food insecure, were now food insecure. So right before the pandemic, they may have been doing fine, but now they can't have caregivers come into their homes. Family members are staying away from their homes. They have functional and cognitive disabilities that are keeping them from leaving their home already, but now we add the added element of possible death by going to the grocery store because of infection. And so we had a situation where we had several people who were now food insecure that weren't previously. So we actually had the medical students call all of our house call patients and ask them if they were having problems getting access to food. And then I partnered with a pediatrician friend of mine, Kimberly Montez, who was also seeing food insecurity in families. And so she and I worked together to actually jumpstart a food delivery program for people. So it did not start out as a study. It started out as a mercy project. And then I was actually in the middle of doing my implementation science certificate through UCSF. So I kind of said, you know what, I wonder if I can turn this into a study. Like, could I start evaluating it, some of the outcomes of the program, because it kept going and I wasn't expecting it to keep going. And so that's sort of what led me into the opening spaces of looking at produce prescription models, thinking about outcomes of food insecurity, but also addressing food insecurity. And then also thinking about the global federal programs that are addressing food insecurity and the barriers for older adults accessing that as well. So I think about all these different lenses now, but I think it all started in those moments.
It just started with you being nosy and looking in people's cabinets and refrigerators.
It
All
really
started
did.
that.
It really did. I'm ashamed to say that, but yeah, it really did.
But that's what home health is about, right? Being a detective. So we know about your anecdotal findings in, especially during the pandemic that we've come out of. But what does the data show us about this growing food insecurities, especially in older adult households?
Yeah, so there's a ton of evidence on this, actually. So one thing I want to point out is food insecurity disproportionately impacts people who are Black or Hispanic. So you will see that the rates of food insecurity for older adults globally are around 10%. But if you stratify that by race or ethnicity, it's around 20% for Black and Hispanic communities. So that's the first thing I wanted to point out, because sometimes people will think, well, older adults don't have food insecurity, that somehow that's taken care of as you get older. But unfortunately, that's not the case. Secondly, having chronic disease or a functional limitation actually is a strong predictor of having food insecurity. So those are a couple of things to think about. Someone who's a low-income older adult that has a functional limitation, they have about a 70% higher odds of having food insecurity or having poor diet. And then also there's a ton of health conditions and outcomes that are related to food insecurity. So depression is associated with food insecurity. Functional limitations are associated. Worsening congestive heart failure for reasons that I had mentioned as well, hypertension, peripheral artery disease, osteoporosis, gum disease, you name it. So the interesting thing is depression is sort of an emerging conversation. Rachel Bergman did a study in 2020 looking at, well, does food insecurity actually have association with depression in older adults? And she was able to show that it did. So that was something that I think is important to think about. So when I've been doing our studies, I've been looking at mood as a part of our outcome measures, specifically because I'm really interested in that piece of the puzzle. So we did get pilot data on our program, and we were able to show that we significantly decreased food insecurity, increased fruit and vegetable intake, though not significant, not with a significance. But we also noted that depression and loneliness, we measured that before and after the program was over, and it actually stayed stable or actually improved during the time that that the patients were in the program. So we had that program going from 2020 through October of 2021, which lasted much longer than I thought it was going to. But we noted that around the 6-month point, we started seeing improvements, especially in food insecurity. So yeah, I think those are things to think about when you're thinking about the tie between food insecurity and health outcomes. And then also addressing food insecurity is important to think about too. So, we currently have a USDA funded study that I'm running where we are looking at health outcomes, mood outcomes, and then healthcare costs of the people that are enrolled in our study over time. But there's already been other studies that are starting to show, like Seth Berkowitz, he published in 2021 with Dr. Palak Shapa, who's a good friend of mine, a study looking at, okay, does SNAP actually, so the food stamps, right? Does food stamps improve health outcomes for older adults, and does it decrease healthcare costs? And the answer is yes. So there are emerging studies that are showing that just by addressing food insecurity, you can actually improve health outcomes of older adults and decrease healthcare utilization and healthcare cost. So we're also looking at this as well. And then when you look at SNAP, which that's the Supplemental Nutritional Assistance Program, we call it SNAP. Everybody else calls it food stamps. That's, what we would call like a global first line defense against hunger for older adults. But we're also finding that over 60% of older adults who are eligible for SNAP don't have it. And there's a lot of known barriers to that. A lot of it has to do with technology or even confusion about how to sign up. In North Carolina, you have to show documentation, to get SNAP benefits. And in fact, my own mother is eligible for SNAP, and she won't even let me help her sign up because she said, I'm too confused by it. I don't want to have to deal with it. And even with me walking her through it, she won't even sign up. It becomes a barrier, a cognitive barrier for a lot of people. So I do want to kind of point out there are things that we could be doing to help remove some of these barriers as clinicians, especially as older adult clinicians, people who care about older adults.
So that makes perfect sense to me about patients just when it comes to their financial they don't want to disclose, for various reasons to get assistance. So that I certainly understand that. When we hear the term food desert, is that referring to healthy foods where all you have in your access is maybe a convenience store that has processed and that's the last thing we want our heart failure patients to get is more salt? Is that what it refers to, or is it more of a general food insecurity?
Yeah, I was actually chair of our regional food council, and we had this conversation because we did a regional food assessment and we wanted to define food deserts, because food deserts has a definition that's sort of widely accepted. It's no grocery store within 5 miles of a house, but it's much more complicated than that. What we find are additional factors that you have to think about for people who don't have access to grocery stores in their community is transportation barriers. For example, in Winston-Salem, there was a study done on transportation here. And so for someone to go 20 minutes on the bus, it took them actually over an hour and a half, because it took about a mile to walk to the bus stop. And then, all the bus stops along the way, and then you finally get to your location. So even if you have a grocery store that, let's say, is, 10 miles away, getting there and back, and then you have to think about, well, if you're relying on bus transportation, what can you carry to the bus and take back home, right? So, and what's going to last that long? So can you get fresh and frozen vegetables and bring them with you? So that's actually part of the reason I started a produce box delivery program, because we were trying to overcome some of the transportation barriers that older adults specifically had in places that we called food deserts in our community, where there's, only one grocery store within a few miles of communities.
That was very smart thinking. I mean, for years, we've tried to prescribe prescriptions for healthy foods, but when they're not accessible. So it makes perfect sense for you to prescribe fresh food like you would an exercise prescription for patients. So fresh food prescription programs like this Fresh Food RX have been shown to increase their healthy eating. Access is certainly going to help. What did you learn about the creation of Fresh Food RX? And what were some of the participants' perceptions and themes that you identified when you looked overall at your program?
Yeah, those are good questions. So I think I learned a lot. The first iteration of our program, I actually partnered with local and regional farmers to support local economy. So we paid for local produce, but that meant that we were doing the procuring, the cold storage, and the packaging of the boxes in partnership with the farmers. And I never want to do that. I love the farmers. I just never want to have to do that part again.
What sounds good on paper doesn't always pan out logistically. So
it's a cold nightmare. So we had to we use Google Maps to its fullest capabilities. It was quite comical. So doing the logistics of the driving and everything. So what I learned was an operational partner is really important. So this time around we've partnered with a for-profit company that is really interested in addressing food insecurity, and they source from regional farmers within North Carolina and provide options for our patients. So that's one thing. The other thing is I did base our program on theory. So I use a behavior change wheel. So we're not just looking at access, we're looking at, knowledge and skills. We're looking at functional ability and cognitive ability to be able to engage with the program. We have health coaching as a part of our program. And then we've also learned that not everybody wants to do health coaching, and that's okay, right? They just want the access to the food. And so there's different motivations. And that's the other thing that the behavior change wheel is good for. It looks at your intrinsic and extrinsic motivations for being a part of the program. And then you build off of that to help encourage healthy goals and individual goals based on the patient's priorities. So I think I've learned a lot about, what I think might be best for somebody, they may not think is best for them. And then also the importance of their input into a program. So I do qualitative research, and we were able to do interviews during our first round of food prescriptions. And we learned a ton from the participants on what made the program go well, what could have gone better. They also, our themes were basically that we removed logistical barriers to accessing healthy foods. They felt that their well-being and their health had improved. They had said that their dietary habits overall were better. And then also that they felt that their financial well-being was better, but also their health outcomes were better. So we didn't have a large enough group of patients to measure the biometrics on for, like blood pressure or lipid profiles. We didn't do that for the first study, but we would get anecdotals from the interviews, my A1C is down, my weight is down. And in fact, in the current program, we have a patient because this is a study this time. We have a patient who's lost 50 pounds in 6 months. So, and she, feels much better. Her knees are not hurting as much. So we're finding even, these great health benefits more than what we thought that they would have with a $25 produce box every week. It doesn't feel like a large dose, but at the same time, it's just enough to get people going.
That $25 seems very, very well spent when you look at some of those outcomes. What's your next step in tackling this particular social determinant of health? Are you moving beyond North Carolina or just beyond Wake Forest, or what's next?
So one of the great partnerships I've really appreciated being a part of is the Food Research and Action Center. They do a ton of work in looking at the importance of SNAP and doing policy advocacy around improving access to SNAP, especially for older adults. So I've been working with them. We worked on a healthcare provider survey that was a national survey, and that's on their webpage. And we wanted to know from the perceptions of older adults, healthcare providers who provide care for older adults. So we wanted to know, are you screening for food insecurity? Are you addressing food insecurity? And so we were able to get the responses back from those surveys and look at where are the gaps and opportunities for addressing food insecurity in a clinical setting, especially with people who provide care for older adults. And so there were some recommendations made. Some of those recommendations were, there's some great modules that are out there that actually teach you about how to address food insecurity for older adults if you're a healthcare provider for older adults. And that's on the Food Research and Action Center's webpage. And that was in collaboration with AARP, I believe. And then also, there was a lot of need for technical assistance, a lot of need for understanding how to utilize your team, and so that you can work together to address some of the needs. And then also, a lot of providers brought up just time, right? The time limitations of addressing social drivers of health like food insecurity in the current clinical settings. We always have, as a healthcare provider, I know we have a lot of competing needs that are coming up during a visit. So trying to figure out how do you triage that inside of your existing framework. I think those were some things that were brought up. I'm also with FRAC, we just put in for, hopefully it'll get funded, but we're interested in looking at SNAP benefit outcomes for people who have diabetes from a statewide level, especially because SNAP benefits before the pandemic SNAP benefits went up during the pandemic. So if you have an older adult who has Social Security benefits, the average amount that they would get would be around $25 to $30 a month, which, is not very high at all. During the pandemic, everyone got maximum benefits. So that same older adult, they went up to around $200 a month for their SNAP benefit. Well, that continued until March 1st. And then March 1st, they went right back down to the pre-pandemic level. And so we're really interested in looking at health outcomes before, during, and after those changes to see what those impacts have had on the participants' health overall. So that's something that I'm interested in as well. And then, of course, our USDA-funded study is a part of a national cohort. So there's other produce prescription programs around the country. We all do things a little differently, but we also have collaboration in that we have some measures that we're all collecting together. So it's really interesting to see, what's the national impact of work that we're doing, and then also what's the economic impact of our work as well. So I'm really interested in looking at those reports every year.
So you've certainly, hit on things that we've not been able to leverage just by, saying, here, take your diabetes medicine, here, eat a 2-gram sodium diet, and I'll see you in 3 months. And hopefully you stay out of the hospital. So this is exciting work you're doing. So just by looking in cabinets and a refrigerator, look, you've created a whole research trajectory for you.
I guess there's benefit to being nosy.
Yes. So is there any parting words you would like to share with our GAPNA community?
Yeah, as a nurse practitioner, I think that I've always said this, and I said this in my recent presentation to other nurse practitioners, that I feel like we're like built for this type of work, right? Like in our training, we think about preventative care, we think about the whole person, we think about the context that they're living in. So I just wanted to kind of say, or encourage other colleagues to feel empowered, that their perspective is important. And so, going back to what I said at the beginning, I didn't realize that my perspective wasn't unique or important, but I think that we collectively, as a nurse practitioner APRN field, we have unique perspectives. I think they're valuable. And I just wanted to at least end with encouraging others to take steps to think about, how their perspectives could be informing their practice and maybe even changes in their own community. So yeah, maybe I'll end with that.
Thank you so much. Small changes can have a big impact, and certainly with our patients. I appreciate your time so much, Dr. Zimmer. And this is Dr. Cassandra Von Ness saying goodbye for now, and everyone take care of yourself and take care of others.
GAPNA Chat is owned and produced by the Gerontological Advanced Practice Nurses Association. All rights reserved. No portion of this podcast may be used without written permission. If you are an advanced practice nurse caring for older adults and want to further your career, GAPNA encourages you to sit for the Gerontological Specialist Certified exam and earn your GSC credential. This expert certification distinguishes APRNs with the knowledge and experience to manage the complex health needs of older adults. Visit gerocert.org to learn more. Dr. Rachel Zimmer is an adult gerontological nurse practitioner and assistant professor at Wake Forest University School of Medicine in Winston-Salem, North Carolina. Dr. Cassandra Von Ness is the Nurses Improving Care for Healthsystem Elders Niche Coordinator, Geriatric Oncology at the Moffitt Cancer Center in Tampa, Florida. She is a member of the Gerontological Advanced Practice Nurses Association communication team and is a host of the GAPNA Chat podcast series. For archived episodes of GAPNA Chat and to learn more about the Gerontological Advanced Practice Nurses Association, visit gapna.org. You can also subscribe to GAPNA Chat everywhere podcasts are found.